Good evening, Dr. Phil here. Today we'll be discussing on accidental awareness during general anesthesia. The 5th National Audit Project of the Royal College of Anaesthetists and Association of Anaesthetists of Great Britain and Ireland, NAP5, reported an overall incidence of AAGA of 1 in 19,000. AAGA occurred in 1 in 8,000 of patients given neuromuscular blockers and 1 in 670 patients undergoing caesarean section. 50% of those experiencing awareness reported some form of psychological distress afterwards. The most significant manifestation is post-traumatic stress disorder. Definition of explicit awareness is spontaneous or prompted recall of intraoperative events, which may or may not include pain. The definition for implicit awareness is some degree of cortical perception, but without conscious recall. Case scenario: a nurse from orthopedic ward informs you that a patient you anesthetized 1 week ago claims that he was awake during his orthopedic operation. He is upset and wants an explanation. A guide on how to approach this scenario: first, introduce yourself to the patient and discuss in the presence of a witness, such as a ward nurse. Confirm the facts, listen to the history and find out what does he recollect. Offer an apology. Explain that all precautionary measures were taken, such as machine check, choice of drugs, and monitoring. Explain why AAGA occurred. Explain that the patient was unstable following polytrauma, and you had to be careful with administration of drugs, and not administer doses that may cause dangerous hypotension. The administered dose of anesthetic may have been inadequate to provide adequate anesthesia in order to avoid the said dangerous hypotension. It was possible during the period of instability that the patient had AAGA. Find out whether the patient felt pain during his awareness. Mention that AAGA is a rare but possible complication when anesthetizing unstable trauma patients. Arrange an interview with the consultant anesthetist and offer follow-up a week or a month after discharge. Offer to organize psychological support. Reassure that future GA can be safely provided. Explain that everything is documented. A letter about the incident will be written to inform his GP. Ask whether the patient wants to know anything more. Additional tips for managing the impact: be courteous, sympathetic, and develop rapport. Keep conversation and procedures in the OR respectful to the patient. Interview the patient after procedures. Take a detailed account of the recollections if present. Assure the patient the credibility of his or her account. Notify the surgeon and other key personnel. The Bryce Protocol. This is a post-anesthesia questionnaire used by anesthetists to detect awareness based on a study by Bryce et al. In 1970. Timing of questioning includes on waking, in the following 24 to 48 hours, and after 2 to 3 weeks. Questions included in the Bryce Protocol includes: what was the last thing you remember before going to sleep? What is the first thing you remember on waking up? Can you remember anything in between? Did you dream during the procedure? What was the worst thing about the operation? Additional questions for patients with post-op recall to complement the questions in the Bryce Protocol. What did you notice? Pain, paralysis, sounds, or vision? Did you feel something in your mouth or throat? Were you able to move? What went through your mind? Did you think you were dreaming? How long did it last? Did you try to alert anyone? Did you inform the anesthesiologist or hospital staff? Have there been any consequences? Do you sleep well at night? Classification of AAGA can be classified according to the Michigan Awareness Classification Instrument 2010 or the Classification of Intraoperative Cognitive States by M. Wang et al. 2012. Risk factors for AAGA includes underdosing of anesthesia relative to a specific patient's requirements. This is the single most important cause of AAGA. Use of neuromuscular blocking agents doubles the incidence of AAGA and increases the likelihood of painful awareness and subsequent PTSD. Surgical factors includes cardiac surgery, cardiopulmonary bypass, emergency surgery including trauma, and obstetric surgery. Patient factors include severe aortic stenosis, pulmonary hypertension, ASA 4 to 5, cardiac ejection fraction of less than 40%, marginal exercise tolerance, long-term use of opiates, benzodiazepines, anticonvulsants, and cocaine, daily alcohol consumption, protease inhibitor use, end-stage lung disease, pediatric population, and previous AAGA. Anesthetic factors include use of muscle relaxants, underdosing of anesthesia, difficult intubation or prolonged airway management, non-propofol, non-volatile based anesthetic techniques. Causes of AAGA. Equipment and apparatus. Failure of the apparatus to deliver adequate anesthetic agent, such as faulty or empty vaporizer, leaking breathing system, inadequate fresh gas flow, faulty TIVA syringe driver, occluded infusion tubing, misplaced venous cannula. Use of equipment and apparatus. Failure of the anesthetist to use the equipment properly, such as inadequate fresh gas flow while using a circle system during the initial 15 minutes post-induction. Monitoring. Failure to monitor the concentrations of the inspired and expired volatile agents. Regarding TIVA, TIVA is more difficult to monitor because the effect site concentrations are calculated rather than measured directly. Pharmacology. Dose of induction agent may be inadequate, as may be the alveolar concentration or the computed blood concentration in target controlled infusions. Awareness is not prevented by hyperventilation, the use of nitrous oxide and oxygen alone, and opioids. Muscle relaxant drugs are not anesthetics. Anesthesia should not be discontinued until their effects have been reversed in full. Physiology. Rarely a patient may be resistant to anesthetic agents. Possible risk factors include alcohol abuse, drug of abuse, high anxiety, and a moribund patient that adequate anesthesia is incompatible with maintaining hemodynamic stability. The anesthetist should be alert to the clinical signs indicative of inadequate anesthesia. Airway problems and bronchoscopy. During a difficult intubation, the effects of the induction agent may wear off before those of the muscle relaxant. Patient is also at risk of AAGA during some anesthetic techniques for rigid bronchoscopy, such as those using insufflation or injectors. Cardiac bypass increases the risk of AAGA. Prevention of AAGA. Preoperative and on induction. Evaluate for risk factors of AAGA. If present, consider increasing administered anesthetic dose if it is safe. Consider administering a benzodiazepine as an amnesic pre-medication. Check all equipments, drugs, and dosages. Ensure all drugs are clearly labeled and infusions run into patent veins. Redose IV anesthesia when the delivery of inhalational anesthesia is difficult, such as during long intubation attempt or rigid bronchoscopy. Intraoperative measures. Avoid administration of muscle relaxants whenever possible. If muscle relaxants are necessary, use the minimum dose necessary. Monitor the degree of NMB with a peripheral nerve stimulator and assess the adequacy of reversal. Administer at least 0.7 MAC of the inhalational anesthetic agent. Set an alarm for low anesthetic gas concentration. Ensure adequate analgesia. For TIVA, ensure that settings are correct. TIVA machine and infusion tubing not faulty. Dedicated patent IV cannula, visible to be assessed intraoperatively, and consider depth of anesthesia monitoring. Post-traumatic stress disorder following AAGA. Mental distress is reported in up to 50% of those experiencing AAGA, with the most extreme psychological outcome being PTSD. Half of all patients being paralyzed following administration of a neuromuscular blocker, but being awake, develops features of PTSD. Diagnosing post-AAGA PTSD can be difficult. There is a resistance to further medical contact. Presentation can occur a long time after the event. The patient may be reluctant to volunteer information about the traumatic event without direct questioning. The patient prefers to block out the painful memories. This may affect males more than females. ICD-10 diagnostic criteria for PTSD. A. Exposure to a stressful event or situation of an exceptionally threatening or catastrophic nature, which is likely to cause pervasive distress in almost anyone. B. Persistent remembering or reliving of the stressor in intrusive flashbacks, vivid memories, recurring dreams, or by experiencing distress when exposed to reminders. C. Actual or preferred avoidance of reminders of the stressor. D. Either of the following. Number 1. Inability to recall, either partially or completely, some important aspects of the period of exposure to the stressor. Number 2. 2 or more newly arising persistent symptoms of hyperarousal, such as difficulty in falling or staying asleep, irritability or outbursts of anger, difficulty in concentrating, hypervigilance, and exaggerated startle response. For diagnosis, criteria B, C, and D should be all met within 6 months of the stressful event. The patient may be diagnosed with anxiety or depressive illness. Treatment of PTSD includes cognitive behavioral therapy and eye movement desensitization. Listening, patient reassurance, expertise, and attention to detail reduces preoperative anxiety and even risk of AAGA. Audit of practice. All anesthetic departments should audit the incidence of definite or probable AAGA. The ideal standard is that no patient undergoing general anesthesia should have awareness. However, in line with published data, the following targets have been recommended. For general surgical case, less than 0.2% should have AAGA. For obstetric anesthesia, less than 0.4% of women should have AAGA. For cardiac anesthesia, less than 1% should have intraoperative awareness. These are my references. Thank you.